Okay, so we are extremely pleased to have with us David Sridhar. Professor Sridhar is at the University of Edinburgh and the founding director of Global Health Governance Program. And she also worked at Oxford University as an associate professor in global health policy. And she's the author of numerous publications on. One second. Sorry, can you stop it? Thank you. She's the author of numerous publications in Nature, Science, New England Journal of Medicine, The Lancet, British Medical Journal. And she has authored impactful books like Governing Global Health, Who Runs the World and Why, The Battle Against Hunger, Choice, Circumstance, and the World Bank in 2007. And she also published this book, Preventable, How a Pandemic Changed the World and How to Stop the Next One with Penguin. It's an important book because it highlighted the importance of preparation and political leadership in altering the course of the pandemic, revealing valuable lessons for building a more healthy and resilient future in terms of public health. So we are very happy to have Devi with us, if we may, that she will talk about her book, but also she will focus, and we will have a fair amount of time for questions and answers on the topic on what could we do to save lives during the COVID pandemic, and if there are lessons we have learned and we can learn to save lives in future pandemics, if there will be other pandemics. So without further ado, Devi, you can start your presentation. Thank you.
Great. Well, thank you so much for the invitation, and I'm glad to be able to join your course and share a bit about my experience and work on pandemics. I worked during the COVID pandemic as an advisor to both the Scottish and UK governments, and I also was asked at different points to advise to Germany, India, New York City, different responses. And so much of my talk is coming from a perspective of someone who worked on it academically, theoretically, the idea of it, and then having to actually put that into practice in a world-changing event where actually theories didn't really get you so far when you actually had to decide day to day and give your advice to leaders. And so I wrote a book about my experience, which is there, but I'll try to come to kind of the key nuggets and issues. To get to the heart of what we were doing as scientific advisors is trying to communicate to politicians or decision makers what we know and what we don't know. And this is a way that I used to structure my thinking during the early stages of COVID. And I put it up because I think we have to recognize uncertainty as a basis of science, and that when things are uncertain, that's when you get a lot of differences in opinion among scientists who are all kind of guessing what they think might the answer to be. So I put up a couple, and I'll just go through them. So for example, immunity. I think one of the biggest questions at the start was how many people might have pre-existing immunity to SARS-CoV-2, therefore limiting the extent of how much, a wave of infections turning into hospitalizations or deaths. And we didn't know anything at the start. Now we know, seroprevalence, which is with antibody tests, how many people have had vaccinations or been infected, what we call hybrid immunity. We know the extent of how many people have had it because of those tests that were developed. But we still don't know, and I'm still asked often, how long does immunity last? When do I need my next booster? Will my risk go up or down after a year of not having it? And so again, when you're asked this by a government, it's very difficult to be able to know the exact precise answer to give. And same with health issues. When it first emerged, everyone talked about it like a flu, a respiratory disease. And I think what became surprising over it was, doctors talking about being a multi-system disease. The exact percent of people who develop long-term health issues, what you call long COVID. And even now, they ask questions. Will people from long COVID recover? What percentage of the population will get this? How long till they're back at work with, long COVID being a factor, at least here in Britain, why we have people out of work? We don't know the answer. Vaccines, one of the biggest debates at the start was, will we have a vaccine? And big disagreements among scientists whether we'll have one in time to shift the trajectory of the pandemic. And now we know we do have candidates, but we don't know what'll happen with variants, reinfection. People are confused why they can get vaccinated and then get COVID a month later. So again, answers where it's very hard to give a clear one. And same with treatments and then coming to children. I think children were really puzzling because usually coronaviruses or flu, or just think in general in public health, children under 5 are such a focus of interventions and focus. But instead, actually, younger children were less affected. And we saw this in Scotland because we opened schools really early in August 2020 with surveillance within nurseries, primary schools, and secondary schools. And it was a full return of children to in-person learning with testing in place to understand that in real time. And what we found is about a month and a half, so 6 weeks into reopening, most nurseries had not had cases or 1 or 2. If you went to primary schools, you found a couple. And if you went to secondary schools, there were clusters. You went to university, there was community transmission. And that was really interesting to see. And that all changed with the variants in Omicron, when actually it started spreading through schools, including nurseries. But again, when we were asked, why are children less affected? Why are you seeing fewer outbreaks in nurseries when nurseries are usually the place you would see it? We didn't have good answers for that, and the reason this matters is politicians were trying to decide, do we reopen schools? What's the risk for teachers? How do we get the unions on board? How do we deal with child protection issues in terms of children who are at home? How do we get social workers in? So a lot of these seem like very technical scientific questions, but the answers to them would help inform what happens next. So I thought I would structure the rest of kind of my comments for the next 10 minutes on what I found surprising and what I didn't find surprising living through the pandemic, having worked on pandemics before and having worked on Ebola in 2014 and worked on preparedness plans. And I think this is probably shared by others in the scientific community. So I think we could predict we were going to have a pandemic. It's like right now when we're watching avian flu spread in the United States. It's not going to be a shock to anyone if we start seeing more human cases. It's predictable. And we saw this in 2014. It was the cover of Time. We're not ready for the next pandemic, where we had a bit of a test run with Ebola. But the way Ebola spreads means that actually it's not as infectious. It's bodily fluids, which meant when we had cases in Britain, they were easily stopped. We know that a respiratory, that is something that spreads through breathing, through close proximity to someone who's ill. I don't know if we can talk about airborne versus droplets and that whole discussion, but basically something that's similar to kind of flu-like is very, very dangerous. And Bill Gates was also warning about the risk of bioterrorism. In a sense, there's a question, because this has come up with where did SARS-CoV-2 come from? Does it really matter if it came from a lab or it came from a wet market? In the end, the impact was the same in terms of how it spread. But there was a lot of attention to this. It was not new to those working on this when this emerged. It was kind of, oh, wow, it's a coronavirus. It's not a flu virus, which is what was being anticipated. So we heard about this first on January 5th formally, though before that, there were reports out of informally from China. And this is the way in international health, the cases are detected. So imagine something unusual happens in China or Guinea or South Africa. Under their international legal obligations, they had to report to the country office, which then goes out to WHO Central in Geneva, which tells the rest of the world disease outbreak news. So you might wonder why the 5th of January, everyone wasn't running, given I told you we were predicting this, we're saying it's going to happen. And if you think of responses, it wasn't until even February and March where we actually really got countries moving. And part of it has to do with, first, they didn't mention human-to-human transmission. But secondly, there are so many outbreaks and issues in terms of signals, we might call them. So all the time, WHO and emergencies where things get consolidated in the World Health Organization, they're having to screen like 3,000 signals a month. What is a signal? It's a healthcare worker or a nurse or a doctor in a clinic somewhere in the world saying, this is unusual. I don't know why it's unusual. They're reporting it. They have to choose based on that knowledge what they're going to follow up, what they're going to investigate. Most of these things you never hear about. They remain in a hospital, they remain in a region, they remain in a country, perhaps a few countries, and they go away. And so you probably haven't heard about yellow fever outbreaks or cholera outbreaks, because if you're sitting in Italy, it's not really going to affect you. It's going to affect that, and it's going to be contained. So it's worth saying most things don't become pandemics. Local outbreaks, most are stopped. But we are seeing more and more. Why are we seeing more? Because we have all kinds of creatures. I think there's estimated 1.8 million viruses just circulating in, bats and the, mammals. And we're in close contact with these. And so all it takes is what you call a spillover moment when these animals come in close contact with us that we get infected. And then if it can sustain human to human transmission, that is the crucial link. So to give you the example of avian flu in the States, we've now seen a couple step changes. First, it was found in wild bird populations, select ones. Then it started getting into domestic birds. Think of chicken farms, turkey farms. Then it became endemic in wild birds all over the whole world. Then we see it spreading in mammals. So for example, seals or mammals that might be feeding off of birds. And then we see in the States a step change and that it's spreading among cows, but it's not because the cows are eating infected, you say chicken feed, like ground up chickens. It's actually because it's spreading between them. So we've seen for the first time evidenced mammal to mammal transmission, but not yet in humans. So now when you hear of human cases, it's humans who maybe have a link to cows. If it moves to human transmission, that is the step change where I think every government will say, okay, now it's made the step change, because we know with air travel, things spread. They go around the world and it's impossible to predict this. So when you see modeling over who will be affected, it's generally over flight passenger records. It's which are the hubs, how many people are on that plane, what's the chances of someone to be infected? It's mathematical modeling. And it works. So we know New York was hit really badly, big cities were hit badly, but it doesn't always work. So for example, I don't think anyone could have predicted Lombardy being so badly hit so early on, or that most of Europe was infected from an Austrian ski resort, Ischgl. And actually that was why we saw cases, or that most people in New York were not infected from China, but from people in Europe. So the way people move and when people are hit is kind of predictable, but it's also not predictable in that way. But we can simply say, if something emerges, it doesn't matter if it's California or it's Seoul in South Korea, or it's here in Edinburgh, it will spread because people spread. And as soon as people spread, it's very hard, as we learn, to stop the movement of people. What we couldn't predict is once this message got out, that people would actually start to fight over things like toilet paper. I don't know if this happened in Italy, but it happened in Britain, it happened in the States, it happened in Australia. And this was really, I remember sitting in an expert meeting being like, what are we not seeing in terms of why people in a respiratory pandemic crisis would be going into supermarkets to scream at each other for toilet paper? I would get it if it was like paracetamol, or be looking for hand sanitation things, or oximeters or something. I was like, the fascination, which led to, here I put a quote up from Professor Murphy, who was the Australian chief medical officer, having to put out official advice saying, this is not a good thing to be doing. Don't go. And again, just shows the difficulty in predicting and public health what we thought might be the crucial points and what weren't. If I turn to what we couldn't predict was how hard testing would be to get out to the public. So this is an article I wrote, and you can see it was March 19th. That was already quite late in the pandemic, if you can imagine where it spread. At that point, health workers in Britain who were working on wards, who were seeing patients with COVID, were not being offered protection and PPE, but also testing, the two ways that they would know if they're infectious and protect themselves. But if you were rich, you could buy it on the private market. And so part of why I wrote this was my medical students. So what they did in Britain was they took young medical students because of the age gradient. So newly graduated ones, some of them were like 23, and their first job was on a COVID ward, because the idea was put the young people onto the COVID wards. And many of them were worried because they either were living at home with their parents, or they had elderly family members, or they themselves were worried about how they were moving through a hospital. And so I think that it would become such a fight to get testing for healthcare workers. Again, I was really surprised about, and testing across the world became a real battle. Should we test? Is it important to test? Does it matter if you have COVID? And I do hope that lesson is learned in the future, because I would have always thought diagnosis through some kind of, rapid diagnostic or PCR that's turned around would have become essential. And it wasn't that early on. It was I think it was about 3 weeks later till even healthcare workers got testing, which was late. We're in April 2020 at that point. I think we could predict lockdown release cycles where various countries in the world went through this. Some places managed to use other measures, but basically the essence of what we were facing. And I remember saying this really early on, that we will be in this for the next 2 years until a vaccine breaks this. And I remember to silence, because people couldn't even fathom it, was that the number of cases without protective measures translated into too many hospitalizations because of the case conversion rate. So that is how many cases that are translated into being into a hospital. I'll give you an example. Early on, Dr. Tedros, head of the World Health Organization, said that 20% of cases were going into hospital. You don't need to be a mathematical modeler to figure out what 20% of a population is. It's come down to about 10% when we found asymptomatic cases with testing. 10% of the population will overwhelm any healthcare system in the world. So what you needed to do was to de-link either the number of cases to hospitalizations, which is what vaccines have done, or you had to limit the number of cases. There's basically two ways out of this. So while, let's say, scientists were out trying to develop vaccines to de-link this, which they have, vaccines have brought it down to about 2%, and Omicron has brought it down to about 1% in terms of how many turn into hospitalizations. The other public health response was, how do we spread out cases so we don't overwhelm the healthcare system? This is called flatten the curve. So every country got this data. Every leader would have seen this, and that's what drove a lot of that we call protective measures. It was the idea that if healthcare collapses, it's not just COVID patients dying, it's if your child has an asthma attack, if you have a heart attack, if you get into a road traffic injury, and then it leads to social unrest, which we did see in Jordan and India and other places where people start like attacking hospitals and healthcare workers because their loved ones are dying and they need care. It just leads to complete disintegration of kind of societal peace. And so that was the essence. And we could predict it from the start that this was going to happen, which was why there was such an impetus. Coming back to countries, they all had trade-offs, and there were very few options. You could either try to eliminate, which is what islands did, New Zealand. So you lock down hard, you clear the virus, and then you keep trying to stop imported cases. And New Zealand managed to go 100 days in 2020 with no cases, with normal life within their borders. So they were having rugby games, music concerts, kids in school, everything normal, but you couldn't get on and off the island without a 14-day quarantine. You could have control, what I would call the German or South Korea model, which is that they realized, I remember talking to a senior German advisor, and he said, we have borders with 8 countries, land borders. There's no way we can seal ourselves off. So he's like, we can have light border checks, but we're going to have to just keep holding and try to contain through, for example, strict rules over super spreading events where thousands of people might get infected, such as concerts, nightclubs, and instead use the test and trace system to try to stay on top of things and use kind of voluntary light lockdown measures so people alter their behavior. And then you had herd immunity, which was the buildup of natural immunity. Some say the Swedish approach, though actually the Swedish would say they took it from Britain because that's where Britain started, which is that we're all going to get it. All lockdowns or other measures are going to do is delay the inevitable. So let's just all get it as fast as we can and make sure your health services don't collapse, keep confidence in the economy, and keep going. What was interesting is you saw different countries start in one place and move. So Britain started in herd immunity when they realized the health services were going to collapse. They moved to control because they moved so late. We went into a very harsh lockdown because we were so late in terms of our growth and our curve. And then you had others like New Zealand who started in elimination, but moved to control because as we got Alpha and Delta and Omicron, more infectious variants, they knew they couldn't eliminate. So in the end, almost all countries ended up in control, whether they wanted to or not, including Sweden, which actually ended up having to close down universities, secondary schools, close down parts of their economy. So though you might have started in 3 places, as the pandemic emerged, you all went into control. If we look now, reflecting back from the Financial Times analysis of data, we can see that something very much was different in certain parts of the world than others. The death rates in the US and UK were astonishing in 2020 and 2021 compared to a place like South Korea. And that came down to those choices early on of, South Korea from January was like, we are going to control this, where I think other places weren't. Then a vaccine happened and every country started moving from control to mass vaccination. So if we look at when countries had to open up, these are 4 that you might have said followed a zero COVID or elimination strategy, Hong Kong, China, New Zealand, and Singapore. They had to come out and tell to their public, you need to get vaccinated, especially over 80s, over 70s. But there was huge variability in actually vaccination uptake in these different contexts. And if we look at actually then what happened, And then you had to pivot very quickly when you got into the Omicron era of a very infectious virus that was going to spread. We have a vaccine. You had to get your population vaccinated. And you can see that actually Hong Kong's death toll passed many European countries, though they had done really well. And that's because they didn't pivot in their strategy fast enough to respond to the changing context, coming back to uncertainty and new information. And so if we look at death rates, and I find this graph astonishing and the best case for vaccination, if you're ever faced by people who say vaccines don't work, this is a similar wave in Hong Kong and New Zealand, and the bottom in red is the deaths for those cases. In New Zealand, because they only had 2% unvaccinated and elderly age groups, the case fatality rate was 0.1%. In that same time frame in Hong Kong, with 66% of over 80s unvaccinated, the case fatality rate was close to 5%. And you can see what that response was. And so you can see the importance of vaccination and changing strategy. What about the economic toll? I think what was also interesting to see, and this is what McKinsey came out with in the Financial Times and economic institutions, was actually the more you controlled your outbreak, the smaller the economic hit. And if you just tried to let's say, let it go, you had a larger economic hit because people didn't trust to consume and go out and go to work and actually have trust and confidence in the economy. So the idea that you had to choose your economy or your health was not a real trade-off. It actually went together. What we could sort of predict was that vaccines would be bought up by rich countries. So early on, this is summer 2020, you can see Canada bought up 9 doses per capita, the US and UK as well. So about 80% of the world's doses were bought up by high-income countries. And again, it was predictable because this had happened before. The consequence was that, a few months into vaccination efforts, you can see Europe, United States, Britain, all pretty much getting their vulnerable groups covered, right? So starting with over 80s, healthcare workers, social care workers, moving down to 60s, 50s, 40s. Look at Africa. And what you saw was actually the first gorilla was vaccinated at San Diego Zoo before the first person in Africa, which gives you a bit about the difficulty in vaccines and inequality in terms of who gets access to products. So we talk about the success of the COVID vaccine project, how much faster we were, but actually that was not shared by everyone. You can see in low-income countries, that took a lot longer. So if you look at the fatality and excess mortality in Africa, it's very, very high, even after we could say the approval of the first vaccines, because they didn't get them. So what we're trying to plan for moving forward, talking about what comes next, is what we call the 100-day mission. And the idea being that within 100 days, we have a diagnostic, that means testing, a therapeutic like an antiviral, and a vaccine, and that we can get this out quickly to the populations. We can talk about avian flu and how it ties into it, but that's going to basically be the plan. They're already prepping vaccines, testing antivirals. They haven't yet mass manufactured in the States. The CDC, I was in a briefing for them and they said it's because they're afraid it might mutate further. So what's the point of stockpiling hundreds of millions of vaccine that doesn't work towards that particular strain? So they're waiting to see what the strain could be, but they're constantly checking. And we have gotten better. I mean, I just want to talk a bit about the success. If we look at how long it's taken to get vaccines and to get the population vaccinated, we can see COVID-19 was the outlier. I mean, less than a year to get a vaccine approved, out, and then by January, people being vaccinated, and then that number going up within 6 months. So that's kind of the model for future pandemics, though, of course, we know, like in the United States, there was resistance to vaccination, and that would be one of the big problems is you can develop something, will people take it? So I'm going to end there. So we're probably just over time at 20 minutes, and happy to have any questions or discussions. I'll stop my sharing there.
Yes, no, that was excellent. Thank you so much. It was very clear, and also we appreciate the fact that we have plenty of time now for questions. I have a few of them, and then I let students, if they have burning questions, to ask. And the first question I would like to address that you already addressed, but I would like to have like a summary of it. What saved lives during the pandemic? So it seems that there was a prevention part that made the difference. You showed the difference between South Korea and the UK or the US, for example. In the early stage of the pandemic, prevention made a huge difference. And that effect really made a difference for millions of people that could avoid death and hospitalization. In the later stage, vaccines became very important. And as you show, the case of Hong Kong that did relatively well during the early stage of the pandemic, so focused on prevention, but neglected the vaccination, ended up to be less than ideal case as compared to New Zealand, that made both prevention and vaccination important parts of the strategy. I wonder whether there were additional factors that could help prevention efforts. For example, what do you think about the role of healthy lifestyles, a good diet, and socioeconomic support of people that had to self-isolate, and all socioeconomic circumstances that made people more exposed to COVID-19? Do you think that we could complement these prevention and vaccination strategies with some further interventions in terms of policy or in terms of health behaviors?
Yeah, no, that's a great question. I think we probably have to break down preparedness to what happens before an outbreak. So what state were you in terms of a healthy population and the trust in government and trust in health authorities? And I think there is completely true. For example, Scotland, we're quite an unhealthy population. We have a lot of chronic disease, child obesity, the risk factors you would see, deprivation, inequality. And so we were not in a good position. So for each case of COVID, our hospitalization rate was higher than a place like Denmark. We were less robust as a population. But almost when the pandemic started, it's too late, right? We can't go back and fix what was there. But for me, like the top lesson for every kind of, when I talk to public health, ministers or others, is actually, what's your population like now? Because you can't fix that during an outbreak. You have to look at it now. And that's actually how I have a new book coming out this summer, and that's how it starts. It's basically like, actually, let's stop talking about diseases itself and let's go look to prevention in a holistic sense. But then I think you get into the phase of you start seeing cases, and that's, I guess, we're talking about South Korea, which is also a healthy population. But then you had to prevent cases, and it was like, what could you do? So you brought up isolation and paying people to stay off work. So this is where testing is important. I try to give the analogy of like an aquarium. So we're all fish and we're swimming around, and we all want to keep swimming around. But a few of the fish are infectious and they're going to make us all sick. So if you can test all the fish and tell the ones who are infectious, actually, we're going to take you out of the aquarium until you can go back in, everyone keeps swimming, right? But if you can't test, then you have to lock down all the fish as if they're all infectious, right? And that's what we did with lockdowns. We basically treated everyone like they were infectious. I don't know how it was there, but here people would pass each other on the street and move because they didn't know, does that person have it? Did they not? Because we didn't have testing. So I think it came down to testing. It came down to support. So even if you know you're positive, can you stay off work for 2 weeks and are you paid? Or do you need to show up? And there, it's not surprising that care home workers who had what we call 0-hour contracts, which means they have to log their hours to get paid. If you're not giving them adequate support, they're going to try to show up to work. And the other thing was masks. We were so late with masks in Britain. If you look at other places, even if it reduces your chances of transmission, everything helped. And then you have, as you mentioned, the pivot towards the next phase. We have a scientific tool. So we have a vaccine or we have an antiviral, and then it becomes about distribution, access, but also people trusting to take it. In the end, you had to have people. And I think that's the real sadness I feel. I met someone recently and she came up to me and said her brother, even after vaccination efforts had been rolled out, didn't take the vaccine because he had fallen into an anti-vax kind of following online, and he died of COVID at the age of 35 after we had vaccines. And so the whole point being, and that's what she was saying, she's like, it's great if you scientists are trying to develop vaccines and get them out there, but if people won't take them because they worry about the side effects, they don't trust it, they think it's microchipping, then it's almost like you don't have a vaccine at all. And I think that's my worry actually going into the next pandemic, is that will we have those levels of uptake, or is there too much distrust of the vaccination process? So, yeah.
I have another question on successful strategies to save lives during the pandemic. The case of Taiwan seems to be really pivotal because Taiwan basically achieved zero COVID without a lockdown and basically adopted prevention strategies without those draconian policies implemented, for example, here in Italy. And lockdowns have been the source of so much distrust, anger, and disappointment. And even scientists, some scientists claim that lockdown didn't make a difference. So there was a third way to go without. So the herd immunity strategy was a complete failure. The lockdown strategy was too draconian. It was the prevention strategy that didn't seem to have enough appreciation, especially among some governments, for sure in Italy. We even had the case of an epidemiologist or some public health experts talk about we are doing too much testing, and that's why Italy is depicted so badly in terms of COVID-19. What's your take on this public health approach that was somehow marginalized compared to the messages coming from medical doctors, modelers, and virologists? And
yeah. The interesting thing is the same debates, I think, happen in every country, because what you're talking about in Italy resonates with everything I've heard in the States and everything I hear in Britain. And I think it came down to the failure to think about testing and tracing and isolation in a more precise way. And also to look at countries like South Korea also never implemented a lockdown in the same way. Taiwan, as you mentioned, Hong Kong, Singapore, there was almost like, I think we spent so long at the start debating what should we do, that by the time we got around to having to do it, it became a lockdown because we didn't have a plan. Where I think the real, like what I would have loved to see at the start was, the smartest minds in a room saying, how do we contain this without locking people in their homes? What are the measures that we can take, as you said, a prevention package of things that we can mean that we keep life relatively going, we limit the amount of illness and death. That was the puzzle. It was not what shall we do in the sense, and I think we wasted a lot of time. And the other two debates I think we wasted time on is, do masks work? So masks work if you wear them properly and they're medical grade. They've been used in hospitals for a long time for risky procedures. What we didn't question is, will people wear masks, in what context, and what are the harms in introducing them? And I wish, again, it would have been a balanced debate, because I can tell you, most people don't like masks. I don't like wearing a mask either. But when they're told the benefit versus the harm, you're like, okay, I'm going to put on a mask in this context. And so we had those debates in Scotland in relation to children, because I was on like a schools committee about reopening schools. Some of the educational psychologists came out and said the harms to children if you put masks on them. They said in under twos, they won't wear them. They'll pull them off. So it's pointless. They said in primary schools, children need to see faces for recognition, for socialization, and those development windows can close if you have masks on. So I really listened to that. That was interesting. I wouldn't have thought of that, being, my expertise in public health, but that meant we made the decision that masks were introduced in secondary schools, but they were not in primary schools. And people were saying, well, you're saying masks don't work in primary and they work in secondary. That wasn't the debate, right? It was finding that balance. And that's, I think, what we didn't communicate well enough, was actually the trade-offs and the balances. We got stuck in kind of circular things over, do masks work, which wasn't even the question, right? It was, people don't want to wear them.
Exactly. Another quick question. We mentioned successful strategies in countries like South Korea, Vietnam, New Zealand, that also Jacinta Ardern had paid some political price for her very vigorous and solid approach in handling COVID-19. And also we mentioned countries who managed the pandemic in a less than ideal fashion. UK, US, Italy, for example. But I did study at UCLA, and I worked at UCL. And I've been exposed to the best schools of public health in the world, in the US and the UK. as compared to Italy, where schools of public health are not even created. A paradox, however, seems to originate from this analysis. Why the US and the UK, with arguably the best schools of public health in the world, have not succeeded in managing the pandemic, having the finest global health experts in the world?
I think it comes down to politics and politicians. And so if you look at in the United States, you had a Trump administration when it came out, and I think there was lots of confusing messages over, we're going to take this seriously. No, we're not. It's a China flu. No, it's not. Go back to normal, drink bleach. And I think it also became a partisan issue, right, between Republicans and Democrats. So if you took the public health crisis seriously, you were a Democrat. And if you didn't, you were a Republican. And even people would, show their political preferences over wearing a mask or not. So I think that was a big mistake there. And I think here we similarly had, there's books written only on the political response. We had Boris Johnson, and he wanted to be the Superman. He said it himself, who was going to ride this through, and gave interviews at the start saying, we're just going to have to see it over the edge. And so I feel like that was what they wanted to do politically until they were forced, because of health system, NHS collapse, into a lockdown. But he only went into that lockdown because they were facing healthcare collapse. If healthcare hadn't collapsed, I don't think we would have gone into that. And so I think that was the difficulty. If we had had different leaders in place, we probably would have had a different response. And it comes back to limitations of being a scientist, where you can communicate risk and facts and information, but will you be heard? I don't know. And you're seeing this now in the United States with many of the appointees. They're political appointees, right? So having someone head Health and Human Services who wrote a book about COVID being a pandemic, and it was all planned for government takeover and vaccines don't work, and that, Fauci, helped manipulate all this. That was a best-selling book in the States by Robert Kennedy, and who is now, Health and Human Services. That tells you that science is political at the highest level. No matter how many great scientists you have in the NIH or CDC, that's the person who they're reporting to. And that's the difficulty, I think, of the reality we live in, which is politics.
So having schools of public health is a necessary condition, but not sufficient unless you have a political system that is going to take on board global health and public health messages from experts. Excellent. Another question. You mentioned the herd immunity strategy that was that seduced, let's say, the UK, Sweden, and also I think Brazil to some extent.
Yeah.
A peculiar turn of the herd immunity strategy was the idea of letting children getting infected in order to create a wall of protection for adults. This was well exposed by a book entitled "We Want Them Infected" by Jonathan Howard, where he also quotes an epidemiologist of the US Department of Health and Human Services saying, infants, kids, teens have zero to little risk. So we use them to develop herd, he meant herd immunity. We want them infected. Data, however, shows that at least the UNICEF made an estimate of 17,491 deaths among children. And a JAMA paper from 2020 to the beginning of 2021 estimated 10,000 hospitalizations among kids only in the US. So it is obviously true that kids had less mortality rates due to COVID than older elderly populations, but the idea that had zero risk was completely false. And what do you think of the strategy of getting them infected in order to protect the adults?
Yeah, I think it's really hard to communicate less risk with no risk. And the truth is that also our tolerance to children getting ill and dying is much less than to elderly people. So for example, if 5 children had died early on, that will create more of a furor than 2,000 people over 70 dying. It's just the way our society and headlines work. So in a sense, you can say they're less affected, but our tolerance is much less because people are very invested in their children and their future. I think it was incredibly dangerous and wrong, and it actually harmed, I think, the debates over children in schools, because it became around, should we get schools back to quickly create a wave and have all the children infected, and without thinking through the consequences. And the truth is, I go through this, I guess, in the book, like when pediatricians raised the alarm was when children were going into hospital with cardiac arrest, with this pediatric multi-system disorder. It's called PIMS. And so they were the ones who were like, we're seeing kids 6 weeks after infection having cardiac arrest in ICU, previously healthy kids. So I remember a meeting of this in April among we had like an expert advisory group. And we were asked by a minister at it, what is the risk? Is it 1 in 1,000? Is it 1 in 5,000? Is it 1 in a million? What's the chances of a child having this? But we didn't know this from anywhere. Only data we had was out of actually Italy and New York City, which had both been hit badly, Lombardy and New York City, with a 10-fold increase in children admitted to ICU in the 2 places that are hit badly. So we had to go back and say, that's what we're seeing. And we don't know the denominator of what the relative risk is of this. It took months for it to find out. But when I hear like people saying about early school closures, I was saying that was the concern, was children. And it was only until August, September, they realized that actually the risk was reduced. And then there was the idea that actually children need to be in school because other risks start to accrue, that we started having these balanced discussions. But in the early months, there was real worry about children. And even someone on our team reached out, he's a pediatrician, to someone in South Korea that he had worked with and said, have you seen this? But South Korea, China, the places that hadn't been hit as badly because they had contained, obviously weren't seeing it. So it wasn't that it wasn't there, it's that children weren't infected. So again, the uncertainty of not knowing. But even now, I think it's, the number of children with long COVID, with exhaustion, the idea that it's harmless, I think was wrong, or that you'd want infection at all. I mean, that, I don't know why you'd want to be infected with any virus or disease in a sense. But this particularly before you had vaccination.
And also you showed that the herd immunity not only failed in terms of public health, because the mortality rates of countries like Sweden, for example, compared much worse compared to Denmark, Finland, and Norway, but also failed in terms of economic protection. So this idea we had human sacrifices in the altar of the economy was completely misguided. Disinformation. So you have been a prominent voice during the pandemic, but this also exposed you to so much attacks on social media, on mainstream media. And this seems to be a situation where there are 2 contrasting issues. On the one hand, to protect yourself from being exposed to this bullying and personal attacks and so on. But on the other hand, the need to have voices, evidence-based messages, prominent voices, public health experts who can fill the gap of misinformation out there. And this seems to be 2 contrasting issues. What's your recommendation on this? Should we stay on our ivory towers and not get exposed to all these social media hysteria and attacks? Or should we get out and trying to change things and change the narratives, being exposed to this, but also trying to inform people through evidence-based?
Yeah, I mean, you saw what I did. So my thing is always to be out there, but I think it's because as much as you see these attacks, they're actually the minority. Like the majority of people trust experts, polls show, and they trust academics more than they trust politicians or other groups. I think what was really powerful was to hear various academics out there giving their logic, giving their advice, giving their, explanation of what they thought was happening, because trust in government was so low. And so, of course, people are not trusting the authorities because they feel like they're being manipulated, or why am I being told this? Or I'm being told, go to restaurants, which is what they did here, eat out to help out because they needed to get the economy going. Yeah. Right. And so they never know if what they're being told is in their own best interest or what the government thinks is actually what needs to be done. So I think the value, and I hope all of you in the class might think about this in different roles, is if you can just say your agenda is public health and you're trying to give the facts, that's incredibly powerful. I didn't say to people, what exactly they should do. I would say, well, this is my take on it. This is where I think it's going. But it does come, I think this is the best way to put it. So if you're on TV, probably 80% of people forget you. They're just like, whatever, another person on TV. 10% of people are going to hate you. You annoy them, your accent or your face or what you're saying. They're just angry. And a few percent might get in touch with you and tell you that because they feel like they need to tell you what they think. And then about 10% will be like, oh, you're all right. I kind of like that person. So if you think that's true of anybody on TV, think of TV presenters, think of sports personalities, anyone, that's kind of our reaction. Most people are neutral. Some really like you, some really hate you. And I think as long as, like, for me, it was really clear, like, I'm not trying to win a popularity contest or become a politician. I have no interest in going into government. I'm happy to be an academic. Then actually you're kind of free from that, right? Because you're not trying to win an election or convince people to vote for you. But of course it's hard. I think the biggest problem, like, thing I took the most hurtful was when people questioned my motives. And they're just like, oh, you're doing this because you are making money off the sale of COVID vaccines. I had no interest with pharma. Or you have this private, because I was a government advisor, I couldn't take on any private advisory roles. So I turned down requests from like Facebook, Johnson & Johnson, GSK, like many of them came to me just being, we want your, and I just was like, I can't, because if I do that, then I'm conflicted, or at least the perception is conflict. So I think as long like you can question, did I get things right or wrong? But to question the motive behind that, that's what really got me. Because if you're in public health or you're in this master's program, you're generally not in it because you're trying to kind of like take over the world or become famous or any of that. You're doing it because you want to improve health and improve society. So I think what frustrated me was that people don't seem to understand that actually people in public health generally are quite altruistic because they chose public health, right, as a career.
Yeah. And that was the point, right? Exactly. Last question from my side, then we will have some questions from the student. You mentioned vaccination and what has been called as vaccination apartheid, right? So you actually mentioned that a gorilla was vaccinated before a human being in sub-Saharan Africa. When Jonas Salk was asked who should own the patent of his polio virus vaccine, he replied, people, I would say. There is no patent. Can the sun be patented? What's your take on patents that have protected the rights of big pharmaceutical companies who got a large amount of money from governments to develop these COVID vaccines, but then they exert their own power and their own right to profit. And they didn't want to liberalize or waive the patents to allow poor countries to get their population covered. What's your take on this?
Yeah, I mean, it's really tricky because the party is like, can you blame the pharmaceutical company for charging as much as they can, right? Most companies do charge as much as they can. And that's when you have government step in, right? And government steps in and regulates that. And so I think what was astonishing is now seeing the backlash, for example, to COVID vaccines. Some people are like, oh, it was just by pharmaceutical companies to make money. They did make an extortionate amount of money and their prices were way above having to cover their costs. But that's where I think, like, for example, in the States, what they didn't do, they launched Operation Warp Speed, but they didn't negotiate the prices with Moderna or with Pfizer. They didn't say, okay, when it comes to market, this is where it needs to be provided. And I think this is a huge problem. And actually some of the backlash to pharmaceutical companies is the idea that they do try to push as high the price as they can, right? Like, and it's up there. And so I think Britain is a contrary example because in Britain, prices are regulated. Pharmaceutical. So we pay far less for our vaccines from Pfizer than the United States pays. And we pay far less for different medications because of government power saying, we're a bulk purchaser. You want access to our market. This is the price. And they have two different branches. You have something called the MHRA, which will say it's safe, it's effective, like the FDA, they regulate. But then they have another body, which actually looks at the pricing, what's going to be made available, which is two separate questions. It's often confused here because sometimes people are like, oh, we don't have that drug because it's not effective. And I say, no, it's not because it's not effective. It's because the price couldn't be agreed. And they've gone for a generic manufacturer or another one. But it's really tricky because in the end, I know WHO and has tried this, but in the end, their companies, if they want access to certain markets, they have to have certain principles behind it. but I don't see it getting better. I mean, if anyone's interested, I did it or like a radio show for the BBC, which is freely available online, called Vaccinating the World, where we went and we interviewed scientists in Africa. And we're asking like the African CDC and the African Union what they think. And they just are like, we want to build our own infrastructure. We want to build our own mRNA facilities. We want to do our own thing because we know that we'll be left out otherwise. So their takeaway from this was that. And also you saw actors like Russia stepping in and trying to get favors with countries by saying, the Western companies aren't helping you, but we'll help you. And of course, trying to use what they call health diplomacy, health aims for getting influence in a region.
So it's the role of government to force corporations to adopt certain policies because corporations are made to increase their profit. At the same time, corporations exert influence over government through regulatory capture. And so it's an interesting topic. So thank you so much, Devi. That was a very interesting. Wow.
Perfect. Thank you so much for having me. I'll get off now so you guys can chat about your next lecture, but it's lovely to meet you all and enjoy the Italian food and Italian weather, which I'm envious about in Scotland.
Yes. So hopefully maybe in the future we can organize something in presence instead of just with a Zoom call. That would be wonderful to have you.
Yeah.
Yeah. Okay.
I would love that. Thank you so much for the invite. Okay, bye.
Thank you, Devi. Ciao.